Hi, I'm Richard Santucci. I'm a transgender surgeon and a fellowship-trained reconstructive urologist. Today we're going to talk about orchiectomy. So orchiectomy is removal of both testicles. In some cases, orchiectomy is used as a genital gender confirmation surgery, and it can be either a standalone procedure where you have the orchiectomy and that's the only procedure you ever want or need, or some people will have an orchiectomy now and perhaps consider full vaginoplasty later when they're ready. In fact, I think orchiectomy is underused. I think that people who are not physically or financially or psychologically ready to have a full vaginoplasty, might consider doing an early orchiectomy. This fits in nicely to people's plans for genital confirmation surgery, and also may have some benefits in terms of decreasing the amount of feminizing hormones that you need. Most people after orchiectomy can decrease the number of hormones that they're on, or perhaps stop spironolactone completely. And for anyone who's taken spironolactone, you know it's a little bit of a troublesome medication and sort of a pain to take, so it's really nice to be able to get rid of that. Some people can decrease their progesterone or stop their progesterone, and some people can decrease the amount of actual estrogen they need. All in all, it seems to be a beneficial surgery. The alternatives to orchiectomy are certainly not to have an orchiectomy, or simply to do the orchiectomy as part of a later planned vaginoplasty. The risks of orchiectomy surgery are those of any surgery. So any surgery you can have, there's a risk of bleeding, infection, the need for reoperation. There's a theoretical risk to damaging nearby structures, although that's pretty low in an orchiectomy. Or the risk that you might develop some sort of complication that really is unexpected. You can invent your own new complication, certainly. The biggest issue with orchiectomy is bleeding. If there's any bleeding in the scrotum is such soft tissue that it'll just keep bleeding and bleeding and bleeding until the scrotum is quite enlarged. And so that is the most troublesome side effect of this surgery. There's several things that you can do to decrease your risk of bleeding postoperatively. The first is not to take any ibuprofen, Motrin, Aleve, or other NSAIDs, including aspirin, because that increases your chance of bleeding for the first 48 hours after surgery. After 48 hours has passed, then you're safe to go ahead and take those medications. In fact, we encourage it because it helps you with your pain control. The second is that you really have to limit your activity that first 48 hours. I pretty much want you sitting on the couch, watching TV with an ice bag on your scrotum. You can walk to the bathroom or the kitchen or walk around the house, but that's the most activity as I'd want. Then, starting day 3, you can liberalize your activity, but I don't want any heavy lifting or heavy activity. No long walks. Don't use this break as an opportunity to clean your garage or get the leaves out of your gutter. Just take it easy for 2 full weeks. At the 2-week mark, if you're doing okay, you can go ahead and liberalize your activity and do whatever you want. The preparation for this operation is pretty straightforward. We follow WPATH guidelines, and because this is an irreversible surgery, once the testicles are removed, there's nothing you can do to replace them. We require letters from your mental health professionals and hormone providers. In general, I wouldn't do any hair removal for this procedure. We need blood work that proves that you're healthy for anesthesia. That's really for the benefit of the anesthesiologist who's trying to put you to sleep as safely as possible. And usually we get a urinalysis to make sure you don't have a urinary tract infection before surgery, which we'll treat. If you have other medical problems such as diabetes or high blood pressure, we'll often ask for optimization and clearance letter from the doctor who takes care of those problems so that they know you're having surgery and they can do whatever they can to get you optimized for that surgery. In general, if you have diabetes, we're going to want really good blood sugar control, and your hemoglobin A1C, which is a measurement of blood sugar over a long period of time, should in general be less than 7. In rare cases, we can discuss whether it's safe to continue if you have a slightly higher hemoglobin A1C than that. You can watch this video as many times as you want and have allies and caregivers watch the video with you if you like. Thank you.